okay. But if you had black and light and brown and, I call them scary looking. I have my students that rotate through the office, and I look at them all, and I say, what do you think? That looks scary looking because it stands out. You can look at a whole body, and there's one that stands out that it's black or it's bleeding. That is significant. The color, and then the asymmetry, if they're larger than 6 millimeters. So just remember that. I mean, this is simple. A, B, C, D, asymmetry, border, color, and diameter. And that way, because the message is that you need to recognize your moles. You need to do self-body examinations, look yourself in the mirror in the front, in the back, or have your partner look at your back, and learn to recognize your moles. Because if you see any change in a mole, whether it gets darker, it gets lighter, it grows, it bleeds, it gets crusty, any change in a mole is significant, and that's when you have to go and see a dermatologist. Let me show you some melanomas. Again, let's go through the exercise. Is it asymmetrical? Yes. Are the borders regular? No. Is the color even? No. And the diameter, so this is a melanoma. This was somebody that had a melanoma. Again, this is another melanoma. Color irregular, border irregular. It's got this funky thing out of there, and it's got that black thing standing out. That's a melanoma. Now, sunlight causes melanoma, and sun protection can probably reduce the incidence of melanoma. There's a load of research being done on trying to specify how can we prevent these cancers, and we now know that sun protection probably reduces the incidence. So that's melanoma. Now, there's two other cancers that we mentioned, basal cell carcinoma and squamous cell carcinoma. This one is the most common. We see hundreds of basal cells in the office. It's an extremely, extremely common. And they basically, it exceeds the incidence of cancers of the lung, breast, colon, rectum, prostate, bladder, and lymphoma. 1,000,002 cases in 2006, and as you can see, it's not aggressive in the way that it doesn't go to other parts of your body, but it grows locally, and it causes tissue destruction. Those are the people that walk around with half of their ear gone, or half of the nose gone, or a big flap on their face. Those are basal cells. Our friend Liz Taylor has had basal cells. So this is just to show you how common these diseases are. Another basal cell, they look like little pearly bumps. Sometimes a little raised area that can bleed or ulcerate or get crusty. Anything that bleeds, it's not, call your doctor, call your dermatologist, because that's a very important trait of these lesions. Another basal cell, a little sore that doesn't heal, or a sore that's bleeding, or a bump that all of a sudden got some color in it. And here's a classic. This is what I call a textbook picture. This one grew. The other thing is a lot of the patients say, oh, I just developed this. They didn't just develop this. They've had that for a long time. It doesn't go in 1 week to this humongous nodule on your eyebrow. It takes months and even years. These are things that if you catch them early, real small, very easy. Sometimes we just burn them, we curette them, we cut them out, nice teeny little scar. We have topical treatment when it's very superficial, so don't let them go this far. Squamous cell. Squamous cell is a little bit more aggressive. It's the second most common one, and they do have 1% metastatic rate. They can go, it depends on the location, but they could go to lymph nodes sometimes. So this one is a bit more aggressive, and the thing is that there's a lot of actinic keratoses are precancerous lesions, and they just look like a little red scaly area, a little crusty, and these we treat with liquid nitrogen. Those, about 20 to 25% of those can eventually become squamous cell carcinoma, so that's why we treat them. And I don't know if you recognize these legs because they've been in the news a lot. Laura Bush had a big squamous cell carcinoma that required a graft. This is a skin graft in here in her leg. So these things can become aggressive if you don't catch them early. This is a squamous cell. These are a little bit more hard and indurated and have more crusting to them. Again, see, a lot more crust, a lot more indurated. And these are this actinic keratosis, which some people think, oh, they're just little hard things, and I just pick at them and pick them off, but it keeps coming back. That's not normal. And these are the ones that can become squamous cell carcinomas. Now, what is photo damage? I started talking about the lifetime exposure of sun, which is what we call chronic photo damage. And you can see these are twin sisters, and you can see the difference in somebody that was never out in the sun and somebody that lived completely out all the time. You develop brown spots, that some people call them liver spots. They're called lentigines. Brown spots, sallow complexion, wrinkling, fine wrinkling, and deep wrinkling. Those are all the clinical manifestations of photo damage from prolonged years and years and years of lifetime of sun exposure. So what is the importance of photo protection? Because now everybody's becoming a little bit more knowledgeable, and people come up, what sunscreen should I use? Is it UVB, UVA? What is this? And which one contributes to cancer, and which ones contributes more to photoaging? Now, if I were to take a little piece of skin and cut it and look at it under the microscope, you would see what we call the surface, which is the epidermis. This is the dermis, and this is the fat. Well, what we do know is that ultraviolet B doesn't go very deep in the skin. So this is the one that causes damage is superficial, and UVA rays go very deep in the dermis. So let me show you what happens. So UVA is responsible for the immediate pigment darkening and also for phototoxic drug reactions, and probably is the one that contributes the most to skin aging because it damages the collagen underneath. Now, UVB gives us our sunburn. Eventually, we tan, and the skin says, ouch, it's a protection from the sunburn, and both of them probably help us in contributing for skin cancer. So because of all these studies, you can see multiple references of all these studies, we know that we have to protect ourselves from both UVA and UVB. Now, little word on, is there a role of UVA in skin cancer? We know that in high-intensity sources, there's little doubt. These are the tanning booths. Tanning beds are really solar simulators, and there is certainly more controversy regarding UVA. Now, we now know that both contribute to cancer development, although UVB is probably more important. Both contribute to photoaging, and UVA may be relatively more important in inducing the changes of what we call wrinkling and solar elastosis. Now, how will tanning beds influence skin cancer statistics? We are very, very concerned. There are states where tanning salons are banned. Unfortunately, we still have tanning salons here, and the risk is very, very high. What we're seeing is that we are seeing an increase of abnormal moles and skin cancer in younger people because they're the ones that are using these tanning beds more. And I'm going to show you a couple patients. This is what they do. They're young, they're hooked, they like their tan, they think they look healthier. And look at what's happening. In sun-protected areas, which is in areas where before, unless you went to certain types of beaches where you didn't need a bathing suit, most people did not develop those weird moles on sun-protected areas. Now we're seeing younger patients with look at this mole. Now you guys know all the A, B, C, D. So this is a atypical mole in double-covered locations. Look at another atypical mole in an area. These are people that have used tanning beds for many years, on and off, young kids, and that's what the problem. Another patient with atypical moles in areas that are double covered.